Hola, buenas tardes a todos. Muchas gracias por su asistencia. Mi nombre es Carlos Celis y en nombre de la Clínica de Asma, de la Unidad de Neumología y del Departamento de Medicina Interna del Hospital Universitario San Ignacio y del Departamento de Ciencias Fisiológicas de la Pontificia Universidad Javeriana en Bogotá, Colombia, les damos la bienvenida a esta reunión académica del Grupo de Rasgos Tratables de Enfermedades Crónicas Prevalentes, GINA 2021, que hay de nuevo. Y quiero presentarles a la doctora María José Fernández, neumóloga, colega, directora del Departamento de Ciencias Fisiológicas de la Universidad y quien nos va a acompañar esta tarde en la reunión. Majo, bienvenida.
Muchísimas gracias, Carlos. Para mí es un orgullo y un honor estar aquí el día de hoy con ustedes, con los invitados que tenemos. Estamos en compañía del doctor Carlos Celis, quien es una persona ampliamente reconocida en todo lo relacionado con el manejo de los pacientes con asma y asma grave. Y tenemos la oportunidad de poder compartir este espacio con la profesora Helen Reddel, quien creo que debe ser conocida por todos ustedes, es la persona encargada de hacer como el chair de todo el desarrollo de las guías GINA para el manejo de asma. Y ella adicionalmente es la directora del Centro Australiano de Enfermedades Respiratorias y adicionalmente trabaja con la Universidad de Sydney. Y bueno, nos va a acompañar el día de hoy para hacer una presentación relacionada sobre GINA 2021 que hay de nuevo. Helen, thank you very much for joining us. We are very happy to have you here with us. And we're really hoping to hear about what's new on GINA Guidelines 2021.
Thank you very much, and for the kind introduction. Thank you. Is someone going to... do I need to click on my slides to make them show?
Yeah, I'm here waiting for you. Are you sharing your slides already?
Yes, so they're already shared. Good.
Okay. Yeah, everything's fine.
Thanks very much. Okay, so thank you for the opportunity to join you today, and I really appreciate your interest in the GINA update, which was published just a few weeks ago. Now, I need to make my slides advance. Let's see. Ooh. Okay. Okay, my slides are not advancing. That's a problem, isn't it? Let me stop sharing for a moment, and I'll try again.
Don't worry. This happens all the time. It's just technology is working against us.
Window. Okay, can you see?
Yeah.
Can you see my slides now?
Yeah, I'm seeing them.
Okay, can you see my statement of interest?
Yeah, it's there.
Good. Okay, so I'm not seeing you on the screen, but I'll just continue with this because I know you can see it. Okay, so just first to declare my statement of interest. So I do participate on advisory boards and steering committees to provide independent medical advice, and I do a lot of independent medical education. And the specific thing to mention is that I was one of the 4 GINA members who actually prompted and initiated the studies in mild asthma, that were 3 of which were funded by AstraZeneca. Okay, so I'm going to give you a brief summary of what's new in GINA 2021. There is in fact a slide set that includes more slides than I'm showing, and you can download that slide set from the GINA website. You can use them for personal use, but if you want to use it for commercial or promotional purposes, you need to have approval from GINA. And one restriction in any case is that you can't change the slides. So just briefly about GINA, it was established more than 25 years ago by the World Health Organization and the National Heart, Lung, Blood Institute with the aim of increasing awareness about asthma and improving asthma prevention and management through a coordinated worldwide effort. Now, GINA is independent. It has very, very little funding. It's only from the sale and licensing of its reports and figures. The GINA report we don't actually call a guideline. It's a global evidence-based strategy that can be adapted for local health systems and local medicine availability. But it is very widely used, so around 500,000 copies of GINA reports and pocket guides are downloaded each year from over 100 countries. And since 2014, we've had a very practical focus. So the report includes multiple flowcharts and tables. Now, an important difference from many guidelines is that the GINA strategy report is updated every year. So twice a year, we do a cumulative review of new evidence across the whole asthma strategy. So we look at meta-analyses, including systematic reviews done with grade methodology. We look at individual randomized controlled trials where there isn't a systematic review. We look at observational data, and we look at qualitative data and take all of those into account. For a full description of GINA methodology, you can find it on the GINA website. And you can download a free copy of the GINA report, the pocket guide and slide set from the GINA website. Now, you'll see this figure in quite a few locations in the GINA report. And this is to emphasize that personalized asthma management is not just about medications. So before treating a patient, you need to confirm the diagnosis if it hasn't been confirmed before. You need to think not just about symptom control, but also about modifiable risk factors, and that's where lung function comes in particularly. Look at what comorbidities the patient has. Particularly important to look at inhaler technique and adherence. Around 80% of patients, and doctors for that matter, can't use inhaler correctly, and adherence is usually around 25 or 35% of the prescribed dose at best. But then also take into account the patient, and for children, the parent, preferences and goals. So then when you adjust treatment, that includes not just medications, but also treatment of modifiable risk factors. So for example, in patients with severe asthma, this is including their biomarkers indicating the type of inflammatory characteristic, and treatment of comorbidities and non-pharmacological strategies. And education and skills training are essential. And then when you review response, it's not just about lung function or exacerbations or symptoms, but also whether the patient is satisfied and whether they're having side effects. So it's not just about medications, and it absolutely isn't one size fits all. Now, just a reminder that 2 years ago, GINA made a very major change in its recommendations about asthma management. And I think it's reasonable to say that this was the most fundamental change in asthma management in 30 years. And this was a recommendation that treatment of asthma with short-acting bronchodilators alone is no longer recommended for adults and adolescents. So this was actually a safety recommendation. It was based on evidence that SABA-only treatment increases the risk of severe exacerbations, and that adding any inhaled corticosteroid significantly reduces the risk. And GINA now recommends that all adults and adolescents with asthma should receive ICS-containing controller treatment to reduce the risk of serious exacerbations. It doesn't mean that we're ignoring symptom control, but just that the importance of serious exacerbations cannot be underestimated. And the inhaled corticosteroid can be delivered by regular daily treatment or in mild asthma by as-needed low-dose ICS formoterol. And this recommendation was able to be made because of the evidence that I'm going to present to you next. But first, I just want to explain that in mild asthma, this is what we call a population-level risk reduction strategy. So think of treating hypertension, where you're persuading the patient to take the treatment because you want to reduce their risk of having a heart attack or a stroke. The aim is to reduce the probability of serious adverse outcomes at a population level. Now, in hypertension or with a statin, individual patients may not necessarily experience, or in asthma even be aware of, a short-term clinical benefit because low-dose ICS formoterol relieves symptoms as quickly as SABA. So it's really important to think of this from the perspective of your health system and from the population level of reducing the burden of exacerbations in mild asthma. Now, this is one of the key changes in GINA 2021. So we've made quite substantial changes to the main treatment figure for adults and adolescents. So you see, we still have that arrowed circle above, so that whenever you're teaching about asthma management, you can always remind the audience that this is not just about medications. So instead of having all of the options combined into a single figure, we've split it into 2 tracks. And the reason for doing that was particularly because there was ongoing confusion about whether low-dose ICS formoterol could be used as the reliever in patients taking other ICS LABAs. And there was also confusion. There was also, we didn't have as much evidence last year as we do this year about the relative benefit of these 2 tracks. So the reason that track 1 is preferred is because using ICS formoterol as reliever reduces the risk of exacerbations, and in fact it was severe exacerbations, compared with using a SABA reliever. So in track 1, whenever the patient has symptoms, they use as needed low-dose ICS formoterol for relief of those symptoms. And for patients with mild asthma, that is also providing their controller treatment that reduces their risk of severe exacerbations. In steps 3, 4, and possibly in 5, they are also taking maintenance ICS formoterol, so maintenance and reliever therapy. And in step 5, of course, the biologic options and the add-on LAMA. Now, we are aware that in many countries, particularly low-income countries, they just simply don't have access to ICS formoterol. And in addition, many patients are stable on a different ICS LABA and not having exacerbations. So you need to have an alternative option if track 1 is not available. So in track 2, whenever a patient has symptoms, they use as needed short-acting beta agonist. And in steps 2 to 5, that is in addition to their maintenance ICS LABA or ICS alone. Now in step 1, which in GINA is for patients who have symptoms less than twice a month, we think it's extremely unlikely that they would agree to take low-dose maintenance ICS every day. And so that's where we're recommending as the primary option, taking inhaled corticosteroids whenever their SABA is taken. Because as you'll see in the GINA report, there is some evidence about that, although not nearly as much as for as needed low-dose ICS formoterol. Now, importantly, if you have a choice, then before considering track 2, you need to check if the patient is likely to be adherent with their daily controller, because otherwise they will be defaulting to SABA-only treatment. So just in summary, so the treatment figure shows 2 tracks for clarity based on evidence about outcomes with the 2 reliever choices across the whole of asthma severity. And I've told you these things. So track 2 is if track 1 is not possible, or if it's not preferred by a patient who has no exacerbations on their current controller therapy. And then treatment may be stepped up or down within a track using the same reliever at each step, or if appropriate, you can switch between tracks according to the patient's needs and preferences, and also according to availability. Now, the reason that GINA made this profound change in the recommendation about mild asthma, there's a few points to make. So the first is that patients with apparently mild asthma, as in having infrequent symptoms, are still at risk of serious adverse events. So around about a third of adults with acute asthma had symptoms less than weekly in the previous 3 months. And it's very difficult for either patients or indeed clinicians to think that that is a level of symptom frequency that needs to have something done about it. Further, there have been a few studies that have shown that around about a fifth or a sixth of patients with either near-fatal or fatal asthma had symptoms likewise less than weekly in the previous 3 months. So it's a very important qualifier that apparently mild asthma is still potentially serious. In addition, exacerbation triggers are unpredictable. So respiratory viruses, pollens, pollution, poor adherence for patients on higher treatment steps. And then part of the problem is that SABA has been first-line treatment for 50 years, and that dates from an era when asthma was thought to be a disease of bronchoconstriction. And it was never actually challenged until GINA started to look at the evidence for SABA-only treatment in 2014. And its role has been reinforced both in patients' minds and in clinicians' minds by the rapid relief of symptoms and the low cost. But importantly, starting treatment with SABA trains the patient to regard it as their number one asthma treatment, and that greatly increases the chance that they will default to it and rely on it instead of on their controller treatment. Now, what is less well known is that regular use of SABA, so even twice a day or 4 times a day for 1 to 2 weeks, is associated with adverse effects. Now, the patient may not necessarily be aware of this, but it's very easily shown in laboratory studies. The beta receptors get downregulated, and patients get decreased protection from challenge responses. They get rebound hyperresponsiveness, and then when they need to take the inhaler, they get less of a bronchodilator response, so they're more likely to need to take more doses. And then a couple of studies have shown that just this short period of regular SABA increases response to allergens and increases eosinophilic airway inflammation. So if the patient is taking more, so higher use of SABA, as distinct from this low regular use, higher use of SABA is clearly associated with adverse clinical outcomes. So dispensing of 3 or more canisters a year, which corresponds to 1.6 puffs a day, is associated with a higher risk of severe exacerbations, and several studies have found that. And then dispensing of 12 or more canisters a year, so a canister a month, is associated with a much higher risk of death. And you can ask patients either how many times a week they use their SABA, or you can ask them how often they need to buy a new one. If they're buying one a month, that's red flag alert. Now, as you know, inhaled corticosteroids reduce the risk of asthma deaths, hospitalization, and exacerbations requiring oral corticosteroids, but adherence is very poor, particularly in patients with mild or infrequent symptoms. So a safe and effective alternative was needed for mild asthma. And from 2007 onwards, myself and 3 other members of GINA were pushing pharmaceutical companies to do studies of as-needed regimens in mild asthma. It actually took about 5 years before we persuaded one of the companies to actually do these studies. So these are the studies that have been done. There have been 4 main studies, totaling just under 10,000 patients with mild asthma. So it's a very robust evidence base. The first 2 to be published were the Sigma studies in New England Journal in 2018. These were both double-blind, placebo-controlled regulatory studies of patients 12 years and older with mild asthma who were either taking SABA alone or were taking regular ICS or Montelukast. Patients in these studies had to be eligible for step 2 treatment by GINA 2012 criteria, so they were meant to be using SABA at least 3 days a week before they were eligible. And they had a run-in on SABA to confirm that inhaled corticosteroids were actually needed. Both of these studies, Sigma 1, which was a highly controlled study, and Sigma 2, which was much more pragmatic, both of these compared as-needed ICS formoterol, in fact budesonide formoterol, with regular twice-daily low-dose budesonide. So that was in both of the studies. And then the Sigma 1 study also had patients on as-needed SABA alone. But all of the patients in both studies took a regular twice-daily inhaler. We had electronic monitors on all of the randomized inhalers, so we know exactly when the inhalers were taken and how often. Then the second 2 studies were open label studies in which the as-needed inhalers were used as they would be in real life. So in other words, without having to also take a placebo inhaler. And importantly, practical was completely independent of pharma. These studies were just in adults, and these were patients who were eligible for step 2 treatment by GINA 2014 criteria. And this was just based on when the respective protocols were finalized. In Novel Start, which recruited patients with SABA alone, over half of the patients were using SABA twice a week or less. So in US guidelines, they would be classified as having intermittent asthma. In practical, 70% were taking inhaled corticosteroids at entry, either low dose or medium dose with poor adherence or poor inhaler technique. And the comparisons in these two open label studies parallel the comparisons in Sigma 1 and Sigma 2. Novel Start had the 3-way comparison and practical the 2-way comparison. And Novel Start had electronic monitors on all inhalers and practical on a subset of patients. So the evidence, to summarize it, and again, just a reminder that this is a very large evidence base. So for as-needed ICS formoterol in step 2, compared with SABA alone, which is the treatment of mild asthma in many countries, and by many patients, even when ICS have been prescribed, severe exacerbations were reduced by about 2/3, and this was seen in both the large double-blind Sigma 1 study and in the open-label Novel Start study in patients previously taking SABA alone. So a very large reduction, even though the absolute risk is not large. At a population level, this makes a big difference. Now, compared with maintenance low-dose ICS with as-needed SABA, for severe exacerbations, as-needed ICS formoterol was non-inferior in the Sigma studies, the double-blind studies, and superior in the 2 open-label randomized controlled trials. And just a couple of weeks ago, the Cochrane collaboration published a systematic review and meta-analysis that found that as-needed ICS formoterol was better than regular low-dose inhaled corticosteroid, including that it significantly reduced the risk of emergency department visits and hospitalization. So very important outcomes for the health system. Now, the reduction in severe exacerbations was achieved with about 25 to 50% of the dose compared with an already low dose inhaled corticosteroid. What about symptom control? So there was a very small difference in asthma control questionnaire at a group level. So the difference was 0.1 compared with the minimal important difference of 0.5. And importantly, that difference in symptom control was not increasing over 1 year. Likewise, for lung function, there was a very small difference, much less than clinically important, and again, not increasing over a year. FeNO was measured in the 2 open label studies, Novel Start and Practical, and this showed a very small difference of 10 parts per billion that was not, again, increasing over a year. So there's no evidence that the underlying disease was worsening without regular ICS treatment. Now, for exercise-induced bronchoconstriction, there was an earlier study, a randomized double-blind placebo-controlled study published in 2014 that showed that using as-needed ICS formoterol for symptom relief and before exercise was better than SABA and similar in benefit to regular daily inhaled corticosteroids after 6 weeks of treatment. And so for a patient on as-needed only ICS formoterol, they don't need to be given a SABA for pre-exercise use. Now for GINA, we didn't just consider the randomized controlled trial results, and I want to emphasize this difference from the approach that's taken in guidelines that use PICO questions. As I've mentioned, severe exacerbations can occur in mild asthma, and they're often unpredictable. So, it's not a matter of saying, oh, well, now you're likely to have a respiratory infection, so I'll start you on regular inhaled corticosteroid treatment. Inhaled corticosteroids are highly effective in mild asthma, but as we know, out in the community, patients are often poorly adherent, and we don't want to make recommendations that are only relevant to highly adherent patients. Now, this one is truly important. Even occasional short courses of oral corticosteroid are associated with an increased risk of long-term serious adverse outcomes. So this paper from David Price found that even as few as 4 short courses of oral corticosteroids over 7 years of follow-up almost doubled the risk of osteoporosis and increased the risk of diabetes, cataract, etc., with clear dose responses. So we can't just think of mild asthma in terms of just treating isolated exacerbations when they occur. We need to think about the long-term risk for the patient and for the health system. As I've mentioned, the difference in symptom control and lung function were not clinically important. And I just want to mention that the primary outcome variable of the sigma-1 study was well-controlled asthma weeks. Now, we in GINA actually disagreed with that as the choice for the primary outcome. And when the GINA Science Committee reviewed the evidence, this outcome was not considered reliable because it was based on an old concept of asthma control. But more importantly, it was systematically biased against the as-needed ICS formoterol group, because as soon as someone in this group took their reliever inhaler on more than 2 days in a week, that week was automatically counted as not well controlled. So that was an important consideration. And then the final one is really important because we know the importance of phenotyping in severe asthma. However, the 2 open label studies measured T2 biomarkers, and we found from that phenotyping is not needed for treatment with as-needed ICS formoterol. So there was no significant difference in the treatment effect compared with as-needed SABA or with daily inhaled corticosteroid in patients who had high or low baseline eosinophils or high or low FeNO. And I think probably the fact that a lot of exacerbations in mild asthma are triggered by external events may have contributed to this, this finding. But certainly patients benefit from as-needed ICS formoterol in mild asthma, even if they have low T2 markers. Now, we've often been asked, why did GINA extend as-needed ICS formoterol to step 1 instead of SABA only? And I'll just run through this briefly. So the first is, we pride ourselves on having evidence-based guidelines, but there is no evidence for the safety or the efficacy of SABA-only treatment. And I've mentioned that starting with SABA alone trains the patient to regard it as their primary asthma treatment. So you have to overcome that as soon as you want to try and get them to take a controller therapy. So from GINA's perspective, the goals of treatment should be symptom control and symptom relief, of course, and risk reduction across the whole of asthma severity. I've mentioned that patients with infrequent symptoms can still have severe or fatal exacerbations, and that even occasional courses of oral corticosteroids increase the risk of serious adverse outcomes. Now, of course, we have indirect evidence from the studies I've shown you, the 4 large randomized controlled trials in patients who were eligible for step 2 treatment. But the distinction between symptoms less than or greater than or equal to twice a month, which is the GINA criterion for step 1 versus step 2, or twice a week, as in the US guidelines, is completely arbitrary, and that has never been evidence-based. There's no plausible mechanistic difference. In GINA, we shifted it to less than or greater than or equal to twice a month because with symptoms twice a month or more in the START study, patients had a significant reduction, almost halving of risk of severe exacerbations with regular low-dose ICS. So that's the reason that our criterion had gone down already to twice a month. So there's no difference in risk reduction in the novel START or practical studies by symptom frequency at baseline. So this distinction is arbitrary. And so you'll see in the GINA treatment figure, we've combined steps 1 and 2 for as needed ICS formoterol. Now, one of the interesting findings that might help to explain this is that even a single day of higher ICS formoterol use reduces the risk of progression to needing oral corticosteroids. This was published a few weeks ago. So what this figure shows in the paper from Lancet Respiratory Medicine, which is actually fully published in 2021, is this is showing what happens in the 3 weeks after the first day that the patient uses here more than 2 as needed SABA inhalations in blue, SABA inhalations if they're taking regular ICS in green, or as needed ICS formoterol inhalations. You can see that as the first day that they used more than 4, more than 6, more than 8 as needed inhalations, the risk of the patient having an exacerbation in the next 3 weeks increases quite sharply. But for patients taking regular ICS, they're in green, or taking as needed ICS formoterol, that short-term risk is remarkably reduced, so by about 75%. And this is consistent with similar findings in the maintenance and reliever studies. This was in the AHEAD study, and this one was shown in the COMPASS and SMILE studies. So it's that rapid increase, just a modest increase in dose of as-needed ICS formoterol that seems to reduce the risk of severe exacerbations. Now, some practical issues. So the dosing of as-needed budesonide formoterol, which is what all of the evidence is so far. So the usual dose, if you use delivered doses, is 160, 4.5, one inhalation whenever needed for symptom relief. Now, the maximum total use in a single day is the same as for maintenance and reliever therapy, a total of 12 inhalations in any one day, which is 54 micrograms of delivered dose of formoterol. In the patients with mild asthma, the average use in the randomized controlled trials was around 3 or 4 doses a week. So these patients did, in fact, have mild asthma. And the analysis of electronic monitoring in the studies showed that very, very few patients got anywhere near 12 inhalations, including even on a single day. Mouth rinsing, we're often asked about, and this is relevant to both MARD and mild asthma, that mouth rinsing is not needed after the as-needed doses based on evidence from around about 30,000 patients. So yes, you advise the patient to rinse and spit out in the morning and the evening, but they don't need to do it during the day. And then which ICS formoterol formulations are suitable? So GINA has referred to ICS formoterol rather than budesonide formoterol. All of the evidence in mild asthma is with budesonide formoterol, but beclomethasone formoterol is approved for maintenance and reliever therapy, and there's no reason to suppose its response would be different for as needed only. Other non-formoterol ICS LABAs can't be used in this way, and ICS formoterol should not be used as the reliever with other ICS LABA formulations because we have no evidence about efficacy or indeed about safety. And then I regard it as very important that you have a specific written asthma action plan. And I've given an example here of an action plan that we developed in 2007 for maintenance and reliever therapy, and we've used it ever since then. And we have modified it in the last 12 months to include as needed only treatment. So I'll ask my hosts to perhaps provide you with that URL so you can have a look at the action plan. Now I've talked about how you step up and down treatment, but where do you start? And I just want to show you that in the GINA figures, we have 2 figures, so this one and this one, showing what you should first assess, and then depending on the patient's characteristics when they first present, this is a suggestion based on consensus at where you start on the treatment figure in track 1 and track 2. And a reminder that as needed ICS formoterol in mild asthma is preferred if the patient's likely to be poorly adherent. Now, what about maintenance and reliever therapy in steps 3 to 5? So there have been a couple of changes in the GINA recommendations this year. So one is, so we already were well aware that that maintenance and reliever therapy was reducing the risk of severe exacerbations significantly compared with the same dose or higher dose of ICS LABA in the double-blind studies of patients who had a history of severe exacerbations. And that's the population summarized in this systematic review. However, in addition, when we went back over the evidence for other studies, so compared with conventional best practice in very broad populations that weren't selected for a history of exacerbations, maintenance and reliever therapy, again, was reducing the risk of severe exacerbations compared with a regimen with SABA reliever. In step 4, so this is with a medium maintenance dose. So some patients do need a medium maintenance dose, but you need to check adherence and inhaler technique first. And we recommend that you increase the maintenance dose to medium by doubling the number of inhalations, because then they're using the same strength for both their maintenance and reliever therapy. But I understand from some discussions a few minutes ago that this may be a problem for you given current funding. And then in step 5, so there's no direct evidence about starting maintenance and reliever therapy in patients receiving add-on LAMA or biologic therapy, but I believe that it should be tried before even considering those add-ons. But if a patient's already taking MART and you put them on a biologic, then switching them back to conventional ICS LABA plus as-needed SABA might increase the risk of exacerbations. So that's why it's been continued across to step 5. Okay, so just briefly to summarise the changes for LAMAs in GINA 2021. So the step 5 recommendations for add-on LAMA have been expanded to include the triple therapies. Add-on tiotropium in a separate inhaler is still recommended for ages 6 years and over. And there are 3 triple therapy combinations that are currently approved in various countries for adults. Now, adding a LAMA to either medium or high dose ICS LABA modestly improves lung function, and there's strong evidence for that, but it doesn't improve symptoms. So there's no point in adding a LAMA if the main problem is dyspnea. For severe exacerbations in some studies, add-on LAMA modestly increased the time to severe exacerbation. Now that's stated as evidence B. Since the GINA report was published, a systematic review and meta-analysis has been published in JAMA that showed that it was significant across all of the studies when they're all combined, but it is actually quite a small decrease in exacerbation risk. And it's important to ensure that the patient is getting enough inhaled corticosteroid, so at least medium dose ICS LABA, before considering adding a LAMA. And then azithromycin, so we've confirmed that this is an option for consideration after specialist referral. So azithromycin 3 days a week has been studied in 2 studies, and there's a new systematic review of the evidence. There's actually no evidence so far from these studies for patients taking medium dose ICS LABA. And in addition, we need to think really carefully about the risk of increasing antimicrobial resistance, either at a population level or a personal level. Just want to very briefly show you the treatment figure for children 6 to 11 years. And there's just a couple of changes here. So one is that low-dose maintenance and reliever therapy has been added in the options. It was, in fact, in the GINA recommendations in the text, and we didn't realise that it had been, that was inadvertently omitted from the figure. And then down in step 1 for children, low-dose inhaled corticosteroid taken whenever SABA is taken is preferable to SABA-only treatment, which is the worst option for children. Other changes, I want to leave as much time as possible for questions, so I'll just show you this briefly. The table of low, medium and high doses of inhaled corticosteroids has been updated, and I want to emphasise this is not a table of equivalence. It's just what would correspond to low or medium or high dose for the particular medication you're looking at. And for mometasone, there's this very interesting effect that when LAMA was added, the ICS dose needed to be substantially reduced. And I've talked about the fact that ICS responsiveness varies between patients, and high-dose inhaled corticosteroids should be needed by very, very few patients because of the risk of side effects relative to the potential added benefit. Other changes. So we are suggesting that if you're describing patients in your study, that you should describe the treatment taken, not the step number, and don't impute severity. So, for example, say that your study is in patients taking medium dose ICS LABA, rather than saying they're taking step 4 treatment, and rather than saying they have moderately severe asthma. The interpretation of ACQ cut points has been clarified, and GINA definitely prefers ACQ 5 over ACQ 6 or 7. And you can read the reasons for that in the GINA report. Withholding times for bronchodilators have been updated. And then in primary prevention of asthma in children, there's a suggestion that for women with asthma who are pregnant or planning pregnancy, that correcting identification and correction of vitamin D insufficiency may reduce the risk of early life wheezing episodes. It doesn't, though, reduce the risk of asthma by the age of 6 years. Okay, and we have plans for future GINA for the coming year. So actually, I've left a couple off this. So we're also going to review the chapter about preschool asthma. And we're hoping to provide a pocket guide for management of difficult to treat and severe asthma in children 6 to 11 years. We're going to go across all of the evidence for allergen immunotherapy. The advice about COVID-19 is on the GINA website. So let me just skip through that. On the GINA website, there's a slide set with about 6 slides about COVID-19 and asthma, and we update that frequently as needed. So this is updated on the 26th of April this year. So the bottom line recommendation is the GINA recommends COVID vaccination for people with asthma. Having allergies to foods, etc., or insects is or even to general medications is not a contraindication to having the COVID vaccines. For patients on biologic therapy, we suggest that it should be administered on a different day. And there's a CDC recommendation of a gap from 14 days from influenza vaccination. So that's the end of my presentation. So I'll just stop sharing so we can switch to questions. Now I need to go back to, so I can see you. Here we go.
Professor Helen, thank you very much for your excellent talk. It was amazing to get all the information coming from you. I want to invite Santiago. I want to introduce you to him. He's currently our fellow at the respiratory unit. He wanted to join us and ask you some questions. And also Carlos, we're going to be here moderating the questions. So Santiago, it's your time to shine.
Good evening, Dr. Reddel. It's an honor to have you here. Thank you very much for your lecture. I wanted to ask you, first of all, a question regarding the definition of mild asthma. I know that you are currently working on it, yes. But it really caught our attention that in this new year for GINA, the first steps are fused together. So I was wondering if you could give us maybe a little heads up or a little spoiler on what is going to be the definition of mild asthma, taking this into account, of course. Thank you.
Yeah. Look, that's a good question. And in fact, I don't know what the result will be. We've already had some discussions about it. And the American Thoracic Society has actually funded a project this year about research questions in mild asthma, and it's going to be discussed there. Just in brief, our concept of severity at the moment is that you can only assess it retrospectively. So when a patient first presents with frequent symptoms and low lung function, that we know that patient may do remarkably well just with low-dose inhaled corticosteroids. Their symptoms may disappear and their lung function improve. That's very common. But they may also be a patient who, you do all of the things right, you step them up through the treatment steps, and they've still got severe symptoms or frequent exacerbations despite high-dose ICS/LABA or even oral corticosteroids. At present, there's no way of distinguishing whether a patient who first presents has easy to control asthma or difficult to control asthma. You have to actually treat them to find out. That works fine for severe asthma. So we've got that concept of difficulty to treat. But there's 2 problems at the mild end. So one is, as I said, you can't tell whether this patient's asthma is easy to treat if they're currently taking SABA alone. And the second one is that to call it mild asthma and give it a very specific meaning, as in your asthma can be easily controlled when we put you on some inhaled corticosteroids, is very different from the common meaning of the term mild. So out in the community and for GPs, when we say mild, they think mild symptoms or infrequent symptoms or symptoms that go away quickly when you take your reliever. And I think we learned our lesson with the term asthma control. We thought it was a great term to use for what we were talking about, controlling all the manifestations of asthma. But out in the community, patients think that control means when I take my inhaler, my symptoms go away, and so I have control over my asthma. So there's those 2 reasons why I think we need some really careful discussion. I am not inclined to encourage you trying to change the meaning of a word that's already in common use in the community. So we need to think of something that's functional as well as that reflects the populations we want to treat. Sorry for the long answer, but it's an important issue.
No, thank you, Doctor. It was really great answer. Thank you very much. I don't know if Dr. Celis has a question now.
Yes, we have another question for the audience. If you choose track 1 and use anti-inflammatory reliever, how do you evaluate control with ACT? The same way as with salbutamol in track 2?
Yeah, so this is a problem, and you'll see in the GINA report, we've said that the assessment of symptom control, if the reliever is SABA, should include the frequency of SABA use. And the reason for that is because regardless of how many symptoms you have, if you're taking a lot of SABA, the more SABA you're taking, the higher your risk of exacerbations. Now, it's the opposite in with as-needed ICS formoterol as the reliever. So that's why we've taken it out for patients, particularly for patients using as-needed ICS formoterol as their only treatment, because if we can see from the studies that patients who are using it not just 2 times a week, but 3, 4, 5, 6 days a week, even every day, still had a significant reduction in their risk of severe exacerbations. So that's a bit of an evidence gap. It may be that the way to do this is to use symptoms, exercise limitation and night waking for everyone, and then separately assess SABA use. I mean, that's one of the options that I think would be open. Now, obviously you can't do that with ACT unless you just leave out that question about reliever use. But with ACQ5, for example, you can use, you don't have the reliever use component.
Okay, now it's my turn. I have a question from the audience, actually from Juan David Cano. He's a doctor who actually likes asthma lots. He asked, regarding step 5 and triple therapy, will the exclusion of tiotropium from step 4 delay the start of biological therapy? How much time should one take to evaluate response to triple therapy?
Yes, so look, that's a really good question. So there's 2 parts to it. So add-on LAMA is not excluded from step 4. It's just not the strongest, it's just not a strong recommendation. So you'll see in the treatment figure down at the bottom, there are other controller options, and add-on LAMA is one of the options for step 4. It's just that the evidence for its benefit there is not particularly convincing. The duration of treatment is problematic because the benefit of adding a LAMA is actually in reducing severe exacerbations rather than improving symptoms. So theoretically, you would need to wait for 12 months before saying that it's unsuccessful. But in an individual patient, if they don't have an exacerbation this year and they did last year, it's very unclear whether that was related to the change in medication. I think we actually need more evidence about baseline predictors of response to add-on LAMA. There's one study that looked at baseline predictors of adding LAMA to ICS that didn't find any particular predictors. But we need deeper analysis of the studies that have been done to see if we can identify who should at least have a trial of add-on LAMA. So these are the sort of, and essentially this was partly from a health system perspective that there will probably be pressure to use the triple therapies in everyone with moderate to severe asthma. And that's going to be costly for the health system. So, if there's not good evidence for it as step 4, then it should be pushed across to one of the things that a specialist might consider. But, more evidence needed.
Dr. Reddel, we also have another question. This is actually a question that has in our pulmonary unit. We have discussed a bit about this, and I was wondering, what do you think about the phenosuppression test for adherence? Because there are some trials that have shown that it's feasible. Well, not feasible, but that has the ability to really catch the patients that are not adherent. The problem is that it's not feasible in every country, in every place, well, in every scenario. So I was wondering if in your unit you use it, and what experience have you had with it, trying to evaluate the adherence of your patients?
Okay, good question. So I've measured FeNO in almost all of my asthma patients for the last 10 years or more, but it rarely changes my treatment decisions. Now, my approach to a test, to using a test, a biomarker of any sort, or, any sort of test that costs money, is that you have to show that it adds benefit over what you can get just by talking to the patient. And if you have an empathic discussion with the patient about adherence, you can in most patients identify those who are actually not taking it. So we've actually got specific wording suggested in the GINA report for how to do this. So, the patient sits down, I ask them, what's your treatment? They say, Serotype twice a day. And I say, how often you're taking? Oh, yeah, I take it every day. So if they start with that, if that's your first question, how often you're taking it, it's like your dentist asking you how often you clean your teeth, right? Or your cardiologist asking you how often you're exercising. A bit of defensiveness. So instead, what we suggest is what I do in my clinical practice. So I say, most people don't use their inhalers exactly as prescribed. So would you say that you're taking it 2 days a week, or less than that, or more than that? Now, that gives the patient permission to be honest with you. And I very rarely get someone who sticks to, no, taking it every single day. Now, the exception to that question is I've learnt the hard way. I have to modify it. If it's an elderly, well-dressed lady, they get absolutely insulted if you imply that they might not be taking it regularly. There are some people who do take their inhalers regularly. And we did a study a few years ago using that empathic question where you start with an assumption they're not taking it and encourage them to be honest. And we found with electronic monitoring that question was highly specific for poor adherence when the patient admitted to it. But in that study, if patients still said, no, I'm taking it 7 days a week, twice a day, then there was actually very little relationship with what they're actually doing. So I think an empathic question, if you get an admission of poor adherence with an empathic question, you don't need to do a test that costs dollars. So I believe in putting health resources where they can do the most benefit. In the studies that have been done, what they showed was that if patients had too high FeNO levels and you provided directly observed therapy or high dose therapy, that some of those patients would suppress their FeNO levels and that it was associated with poor adherence or poor inhaler technique. But that some patients didn't suppress their FeNO levels. And that's really, really important to take into account, that high FeNO doesn't mean poor adherence, and it doesn't necessarily mean that the patient's not taking it correctly. The final thing to say about FeNO is that you need to take into account the patient's lung function. There's some very good, strong evidence that was reported in the FeNO methodology guidelines way back in, it was 2005, and in an allergen challenge study that was published a few years ago, that when lung function goes down, FeNO goes down. So you can be tricked into thinking that the patient doesn't have high T2 disease if their lung function is low. And I've certainly had patients who have had they've got a high FeNO at baseline, they've had a remarkable clinical response to inhaled corticosteroids, and their FeNO has gone up. And then, that was just the short-term effect of low lung function when they were first assessed. So it's something that doesn't appear in any of the clinical guidelines about FeNO, but it's a really important confounder for using FeNO in terms of absolute levels to think whether someone does or doesn't need inhaled steroid. And as I said, in mild asthma, patients with low FeNO and high FeNO, the benefit of ICS formoterol over ICS alone or over SABA was seen in both groups.
There is another question. There is a new concept of super response to biologic therapy and even remission on treatment. Do you anticipate that GINA would include these concepts?
So we need more evidence. I mean, at the moment, there's just some observational studies. In my clinical practice, I certainly see it. You know, there's some patients who 2 weeks after the first dose will say, I feel different. They can't even necessarily say what it is, but they feel different in their chest. You know, I think it exists, but we need evidence to identify who has that feature, because given the high cost of biologic therapy, it's going to be really important to try and improve our predictors of response. Now, really exciting data that is available for using breathomics. So Peter Sturck has spoken of this often. He developed this methodology in the UBioPred study. And it's a much more comprehensive assessment of the patient's characteristics of their asthma than just doing FeNO, which is just one single biomarker that we know is affected by a whole lot of things like smoking and lung function. So my suggestion would be that in any future studies, they should do breathomics at baseline so that we can identify the responders and the super responders. You know, it's so distinctive when it happens that, you know, our numbers don't necessarily reflect it. And in fact, in the published biologic studies, the changes in asthma control questionnaire didn't, I think, in any of the studies reach clinical significance. So they were statistically significant, but less than 0.5. In my clinical practice, it's usually quite a bit more than that. But for some people, it's just night and day between starting a biologic and how they feel after a few weeks.
Okay, I have a question. We have data that supports that the use of the beta-2 agonist inhaler as a reliever therapy is associated with bad outcomes for the patient, exacerbation, hospitalizations, and mortality when it's overused. And there are some doctors and there's a group of physicians that believe that we should ban the use of this type of medications with the patients. But if we stop using the SABA as a reliever, we won't be able to use like the track number 2 because we won't have a reliever for that type of treatment. What do you think about this?
Sure. So GINA clearly does not advise stopping SABA. You know, we've put track 1 and track 2 for a deliberate reason. So there's a few factors here. So one is that the distinction between asthma and COPD is not clear. The definitions overlap, and many patients have features of both asthma and COPD. There's no evidence about whether as-needed ICS formoterol, as maintenance and reliever therapy, for example, is beneficial in COPD. We just don't have evidence. There's one study that's being analysed at the moment, but no evidence. So that's one reason. And the second reason is that there are many patients who are actually doing very well just on a regular ICS or ICS-LABA with as-needed SABA. They're not overusing it, they're not having exacerbations, and they've got good symptom control. And GINA doesn't see any need to swap those patients, right? So that's one of the criteria for using track 2, but you do need to assess whether the patient is likely to be poorly adherent. A third factor is that at present, there's only one randomized controlled trial using budesonide formoterol compared with salbutamol in the emergency room. And before we can convince a lot of physicians, I think, to make the switch across the board, across asthma severity, so we actually need more studies in the emergency department. Because at the moment, when a patient using maintenance and reliever therapy or as needed budesonide formoterol goes to the emergency department, in Australia, what often happens is the emergency department says, oh, no, you shouldn't be doing that. You should be using this blue puffer instead. So, emergency departments are a bit of, a special area where we do need more evidence. And I would be very interested to see evidence, for example, out of out of Argentina, where one of the hospitals has switched away from SABA treatment entirely in asthma. So I think it would be very helpful if we could see before and after comparisons and look at outcomes and adverse effects. But another double-blind randomized controlled trial would be very useful. But to come back to what can we do? Spot people who are overusing SABA. That's really important, and do whatever we can to reduce that. But encourage them to with strategies to try and reduce the use. And my personal practice is not to switch them to maintenance and reliever therapy while they're still overusing their reliever. The rationale for that is that when they're overusing SABA, they will have little bronchodilator response. And so when they take the ICS formoterol for the first time to try it out, they may not feel benefit because their beta receptors are still downregulated. So what I do in clinical practice, and this is a really common scenario in our clinic, is we get patients to decrease their SABA use, and often that also reduces their symptoms. And then once they're on a normal sort of dose of as needed SABA, then I switch them across to maintenance and reliever therapy.
Thank you very much. Well, I'm going to leave Santiago the last question, I guess, because we're running out of time. So Santiago.
Yeah.
Thank you very much, Dr. We have one final question, and it's, well, we know that with this update of GINA, the fork road between track 1 and track 2, the interventions on our patients, well, they will change depending on which track they are. Do you think this in the future will change the moment in which we use other interventions such as phenotyping, phenotypifying our patients, or for example, searching for treatable traits in patients? Do you think this change between tracks will change the moment in which we perform that, or the way we perform that? For example, I throw out an example. Maybe a patient that has a track one or the preferred track, we might search for different traits or perform different interventions in a different moment than the alternative track of the albuterol.
Sure. So far, the evidence in mild asthma is that phenotyping does not identify patients who, this is sort of double negative, doesn't identify patients who don't benefit from as-needed ICS formoterol. And it's different from the comparison between regular ICS and SABA. So if as-needed ICS formoterol is available to you, then that will produce greater benefit than either SABA alone or regular ICS, even in regardless of pheno or blood eosinophils. The current biomarkers we have are just too simplistic to be the answer to precision treatment. I think breathomics has a much greater potential because it's not limited to just individual pathways. And the other thing is just the variability in the biomarkers across time. So there's several studies showing that blood eosinophils vary over the year, and we certainly know that pheno can vary according to whether you've had allergen exposure within the last 24 hours or further out than that, and lung function, as I mentioned. So I think that certainly phenotyping in moderate to severe asthma is important because it can guide your treatment, but there's no evidence at the moment that in mild asthma it benefits. So that's important in terms of think about the patient as a whole. Take into account the fact that we're not just treating asthma. So I emphasize the fact that we put that arrowed circle at the top of the GINA figure to say that in every patient we should be thinking about what's called treatable traits there, but we've called it modifiable risk factors and comorbidities. It's the same thing. You don't just treat the asthma. You think about all of the other things that this patient is experiencing and try and treat them as a whole. I mean, that's what GPs do all the time, actually. the treatable traits concept is more of an academic concept at the moment, and it's very complex because there's so many traits that have been listed, and the thought of a GP doing even a small fraction of those is very challenging. I would suggest that we should be thinking of what's this patient's most important problem, and do they have any problems that we know from evidence, for example, the risk of severe exacerbations, that the patient may not be aware of. So think about it from what is the patient most worried about, and what's the evidence that that they are at greater risk and therefore need intervention. So think of them as a whole.
Okay, thank you, doctor.
Good. Okay.
Reddel, thank you very much for your time, your generosity, for taking time out from your agenda to be with us. We had an amazing lecture. We were able to ask you so many questions we had, and we hope to have you back here with us in the near future. Thank you very much.
Thank you. I really enjoyed meeting you, and thanks for your great questions. Okay, good. Goodbye.
Okay. Bye.
Thank you.
Everyone.
Thank you very much.
Bye, thank you.
Chao a todos. Muchas gracias por unirse y chao a todos.